molecular biology, and an MSc in public health. We can testify that he has a lot of experience. So Mr. Abraham's leadership skills and dedication to service are evident from his impressive track record of holding various leadership positions during his academic career. He was the former president of the Ghana Association of Medical Biochemistry Students from 2016 to 2018. He is a former president of the National Health Students Association of Ghana, that is NASAC, Volta region, and then Western Zone from 2018 to 2019. And he is also the former president of the National Ghana Biochemistry Student Association. That was between 2017 to 2018. He also served as the former chairperson of the University of Allied Health Sciences, SRC Intelligence and Student Affairs from 2018 to 2019. And he is the former president of the Students Representative Council, yes, from 2019 to 2020. To 2020, yes. He is the former president of the Mental Health and Wellbeing Foundation, the Ghana, Australia from 2018 to 2020. And recently, he served as the former president of the National Association of Public Health Students from 2020 to 2022 in July, yes. Abraham is the founder of Visionary Norman Foundation and currently the managing director of SB Star Medical Center, where he continues to demonstrate his passion for serving others and making a positive impact in his community. With his diverse background and impressive leadership experience, Abraham is sure to continue making valuable contributions in the field of healthcare and beyond. Ladies and gentlemen, yes, ladies and gentlemen, this is the speaker we have for today's, this is the first speaker we have for today's webinar. So without much ado, I would like to call upon Mr. Nortey to tell us about hepatitis B, tell us about the epidemiology in Ghana, the picture of it in Ghana, and then tell us about certain preventive and treatment regimes available, yes, for the treatment of hepatitis. So, Mr. Abraham Norman, please, over to you. Yes, Mr. Nortey, please, are you here? Hello, Mr. Nortey. Okay, I think he's having some technical challenges. He will get back to us, but we'll move on to Dr. Kenneth. He is on the call. He is a consultant physician and gastroenterologist. He is the head of gastroenterology, Korle-bu Teaching Hospital. He's a senior lecturer at the University of Ghana Medical School, and he is the CEO of All Round Specialist Virtual Clinic. Yes, he's the former vice president of the Ghana Association for the Study of Liver and Digestive Diseases. So without much ado, I'll hand over to Dr. Kenneth Tachi to please begin today's webinar for us.
Hi, good evening, and thank you very much for having me on this call. Yes, so maybe I should just briefly put on my video so that, and after a while, I'll put it on. So thank you very much for having me on this call. And I must say that I was scheduled to be in Hore at this time, but I was really excited that some group found it important for me to speak to them on World Hepatitis Day about hepatitis. And so I thought I could postpone the travel to Hore. And actually, this is part of the lecture that I'll be giving as a public lecture tomorrow at Hore. So thank you once again. I think it's it's appropriate that as we begin this talk, we understand why this day it's important to us. So just a brief history about the history of World Hepatitis Day. We are commemorating this day because of one man, an American physician called Bloomberg, who discovered the hepatitis B virus in the 1960s, and was subsequently awarded the Nobel Prize for Medicine for this discovery. He went on to discover the testing for hepatitis B and also the vaccine for hepatitis B. Now, this day, 28th July, happens to be his birthday. And so in 2010, the World Health Assembly decided to honor him by celebrating World Hepatitis Day on his birthday. And the whole purpose of World Hepatitis Day is to coordinate national and international efforts at raising awareness about hepatitis, strengthen prevention and control measures, and also increase vaccine coverage, which at the time and still even now are at levels that are quite low. Now, so over the years, many themes have been celebrated. At some point, we've been asked to know about hepatitis B. At other times, we've been asked to think about it. And at other times, we've been asked to act. And then when COVID struck and all the attention turned on to hepatitis, COVID, the thinking was, no, we can't wait. Hepatitis can't wait because it probably is killing more than COVID. And so various times we have been asked to, yes, that's what has been required of us to act in various ways towards hepatitis B and C in particular. But I think that a theme that drives home a lot more to individuals as a theme, the WHO theme for 2023, which is one life, one liver. I mean, this theme was chosen to highlight the important role that the liver plays in our lives, and that without it, we probably would not be alive. And therefore, the need for us to protect it and guard it, if you like, jealously. But still, the Hepatitis Alliance believes that we should not put hepatitis on the back burner whilst we concentrate efforts on other things like malaria, tuberculosis, and only come to hepatitis when all these are under control. And therefore, the theme, if you like, a sub-theme is still that hepatitis can't wait. My duties from here on then would be to do what the whole purpose of the celebration is. One is to raise awareness about hepatitis, to highlight the efforts and challenges at hepatitis elimination, and recommend responsibilities for everyone, myself, your association, and individuals, both those who have and don't have hepatitis B, on what we can do to fight this menace. Let me begin by reminding all of us, and I'm sure many of us know the vital role of hepatitis in our lives. Please just give me a second to address a small distraction. My sincere apologies, I'm back. Okay, sorry about this. So I was saying, we all know the vital role that hepatitis plays in our lives. Indeed, the liver is the largest organ in the body. However, if you're looking at the whole body, then it's the second largest, second only to the skin, which is also an organ. Now, it's not just, it's just not enormous in size, but it's also enormous in function, because the liver performs more than 500 functions, from blood composition to processing essential nutrients, producing essential nutrients as well for the body, storing these nutrients, breaking down toxic substances that come into the body, producing cholesterol, which despite all the bad things we know about it, is very essential for life because that's what creates the cells. So these and many, many other functions, so much so that our lives depend on the liver. In fact, whilst preparing for this, I was reflecting on something. Now, if your kidneys fail, there's a machine that can support you. If your heart fails, there's a machine that can support you. However, if your liver fails, the only thing that can support you is another liver. And so the liver is crucial to life. And I think that one way we can say thank you to the liver is to always make an effort to protect it. And we should look at some of the ways we can protect our liver as we go along. Now, in spite of the very important function of the liver, one disease can destroy the liver, and that disease is hepatitis. Now, the term hepatitis essentially refers to inflammation, or if you like, injury to the liver. So anytime there's an injury, there's a swelling, and there's a swelling of the liver, and that is what we call hepatitis. Now, this can be caused by many things: toxins, many infections. So if you have malaria, you can have a malarial hepatitis. COVID came with hepatitis. Paracetamol toxicity can cause hepatitis. But oftentimes when we refer to the term hepatitis, we are interested in the viruses that affect only the liver. And these viruses can be named from A to E. Of course, there are a few others, but the common ones we talk about are hepatitis A to E. They have their unique characteristics and modes of transmission. However, oftentimes we are more interested in three: A, B, and C. A, because it's for public health students like you, it's of public health importance because it's transmitted orofically, so unhygienic environment, contaminated water and food, you take in, these contaminated substances, you can't develop a hepatitis A. The good thing about hepatitis A is that it's often self-limiting. So you will recover. All we need to do is to treat the acute illness, and then you would recover. In fact, I can confidently say that the majority of us on this call have probably had hepatitis A in the past. Sometimes we probably did not even know. But the one that is of even greater importance, or the ones that are of even greater importance, are hepatitis B and C. Yes, so the ones that are of greater importance are hepatitis B and C for just one reason. These ones, when they occur, when you get infected with them, cause an acute illness, but then they can become chronic. So they stay in your body for much longer period. For A, maximum within 6 months, it's gone. For B and C, the hallmark is chronic hepatitis, which means they stay beyond 6 months in the body. And that is why hepatitis B and C are important, and they can progress to cause severe or significant damage to the liver. And we'll look at this as we go along. Now, for something like that I have described as the modes of transmission, then let me quickly also add that the hepatitis B and C often are blood-borne viruses. Or not often, they are blood-borne viruses. But the major modes of transmission for hepatitis B is mother to child in our environment, not sexual transmission. Indeed, you can get hepatitis B through all the means we know one can get HIV through. but the major mode of transmission is from mother to child. And I shall explain this as we go along. For hepatitis C, oftentimes it's amongst intravenous drug users. And so people who do drugs, they tend to get it. Or if you are unfortunate, hopefully that doesn't happen presently, you get transfused with unscreened blood, then you are at risk of this. Sexual transmission, mother to child transmission, also possible, but very, very rare. Now, this is an infection that affects people everywhere in the world. And as you can see on these two maps, every part of the world is afflicted by hepatitis B to the left and hepatitis C to the right. You can see the places of the hepatitis B prevalence map, which are high prevalence, that we've highlighted in red. If you flip and come to the right side, you'd see again that, unfortunately, some of the places which are afflicted by large numbers of hepatitis B are also afflicted by very large numbers of hepatitis C. For these reasons, hepatitis B is thought that at least 2 billion people have ever been infected, and that means that a third of the world's population have had some contact with hepatitis B, and 240 million people are living with this infection. Of course, chronic hepatitis C has recently become very curable, and therefore the numbers that are living with chronic hepatitis C has reduced from about 170 million about a decade ago to now only about 50 million chronic infections. Unfortunately, however, every year there are still 3 million new infections of both hepatitis B and C. Every day, 8,000 new infections are recorded, and every minute, 5 new infections. So this is still a worrying situation. But just to bring home the facts, the prevalence in Ghana, that this is not just a global issue. Indeed, hepatitis B is common in Ghana, or hepatitis. I used to think that hepatitis C was uncommon in Ghana a few years ago, because in the clinics, I could count the number of patients I would see with hepatitis C over a year. But recently, as effective treatment has become available, I have come to the realization that it is not at all uncommon. Presently, current data suggests that the prevalence of hepatitis C in Ghana is about 8.3%. That is still a very huge number if you consider our population. And that 42,000 new infections are recorded every year, which is quite unfortunate, considering the fact that this is a disease for which there's effective prevention strategy. Now, on the map to the left bottom, you would see the areas which are high, or which have high prevalence of hepatitis B in Ghana. And I can say confidently, even though the Upper West and the Upper East, and of course the Northern region shows the data, are not highlighted on this map because of lack of data, the prevalence there is actually higher than the national average. Indeed, when I have gone to Tamale Teaching Hospital to work, the medical ward is full of people with complications of hepatitis B and C. And so that is probably captured very well in the map for hepatitis C, where you can see that Upper East and Upper West actually show a very high prevalence. Unfortunately, even though the prevalence is high in the northern sector, that again is not represented on this data, highlighting again the real absence of data on hepatitis. Now, what happens when one gets infected with hepatitis, be it B or C? If you are fortunate, and I say fortunate, to get hepatitis as an adult, especially hepatitis B, you would develop what we call an acute hepatitis. You will develop symptoms of hepatitis. So you'll be unwell, your eyes will become yellow, you'll be vomiting. Oftentimes, we will recognize that you're unwell, and once there's some jaundice or yellowing of your eyes, we will suspect hepatitis, we will test you for it. But good thing is that 99% of adults who get hepatitis B infection as adults would recover and not go on to chronicity. Unfortunately, remember I said the major mode of transmission is mother to child in our environment. If you get hepatitis B from mother to child or through that route or as a child, you would not develop any symptoms. So the acute hepatitis phase is asymptomatic. No symptoms, you would not even know you have the infection. This goes on to become chronic. And when you have a chronic hepatitis B or C infection, you do not have any symptoms. And that is where the danger lies. So people do not know they have the infection. And then over time, the liver becomes damaged and they develop cirrhosis. And then this can go on to develop liver cancer. And the two ways by which people die from hepatitis B and C is because they develop complications of cirrhosis or they have developed a liver cancer. Now, talking about death from hepatitis B and C are enormous, both globally and in Ghana. So the global data shows that 1 million deaths from hepatitis are recorded every year. Every day, 3,000 people die from hepatitis, and 1 death is recorded every 30 seconds. So you can imagine the number of people who have died from hepatitis whilst we have been given this lecture. And I say the thing that breaks my heart the most is that every day when I run my hepatitis or gastro clinic, I would see at least 10 young people with liver cancer from hepatitis B or C. And once I see them, I know that they are going to die. A very unfortunate situation. And that is captured in the data to the right, which shows that about more than 3,000 people die from hepatitis B and more than 500 people die from hepatitis C annually as of 2019. We've published data that shows that majority of these deaths, and you can see it up there, more than 75% of people who die from hepatitis, the cause is from hepatitis B. Unfortunately, 60% plus of people who die from this disease are actually aware that they have the infection. Unfortunately, for various reasons, they are not able to access care or treatment, and then they end up developing these complications. If the current trajectory continues, viral hepatitis will kill more people annually than malaria, tuberculosis, and HIV/AIDS combined. I'm sure that you agree with me that at present, we are spending more resources on malaria, TB, and HIV individually than we are spending on hepatitis. And that's why there's a call for us to give more concentration or attention to hepatitis, and that hepatitis cannot wait. Now, if it was just about death, and I say, well, if the disease kills you and you go away, then good. You know, you don't waste time, you don't suffer. Unfortunately, the burden of hepatitis goes beyond just dying. I have seen many people and the psychological burden that is on them, so that somebody has given birth to their children or have had just a fresh baby and they don't want to have anything to do with the baby because they have fear of spreading the virus to their baby. Or a family who has been living and then one is diagnosed that you have hepatitis. Then now they want to live a separate life and not even let the other people know because of the fear of stigma. And they become more, in fact, hepatitis B and C infections are known to cause more anxiety and depression than very, if you like, worse infection diseases like even chronic kidney disease when patients are on dialysis. I've seen people's marriages break down similar to HIV situation, even though this is not a disease that's transmitted sexually mainly. People have lost their jobs even as bankers, as if the virus can be transmitted through counting money. People have been denied access to education. They can't go to a certain school because they have hepatitis B or C, and as if reading a book is a mode of transmission. The cost, the financial burden in evaluating hepatitis B, the viral load, the liver test, the scans are enormous. Cost of treatment of hepatitis B, in fact, not that expensive, but the people who have bought hepatitis C treatment for 30,000 cedis in Ghana, in the US, when hepatitis C treatment became available and the new treatment was costing up to $60,000 to $90,000. So, and managing persons with chronic hepatitis B or C complications, cirrhosis can be enormous. All right. And again, people with hepatitis C, especially, but also to a smaller extent B, develop what we call extrahepatic manifestations. So it's not just the liver, but this same disease can affect your pancreas, may give you diabetes, can affect your skin, can affect your eyes, can affect your brain. And so it has other what we call extra liver, beyond the liver manifestations. Recognizing this huge burden of hepatitis, the World Health Assembly again thought that they must have a strategy to combat this virus. And so in 2016, again, a new hepatitis strategy, elimination strategy was adopted. And that was that for all member countries to reduce new infections of hepatitis by 90% and hepatitis deaths by 60% by the year 2030. Hence the slogan, Hep-Free 2030. We hope that by 2030, hepatitis B and C would have been eliminated. If we are able to achieve that, guess what? We'll be able to prevent 36 million infections and save 10 million lives. Ghana too has an elimination strategy. Unfortunately, when I have checked on the website to try and see what even though there's a document that says elimination strategy, the strategy is not very clear to me. And the plans, the action plans are unavailable. But it's not a lost cause, because even before the WHO or the World Health Assembly came up with a strategy in 2016, Ghana had launched a viral hepatitis policy in 2014 with very, very good vision and objectives to have a Ghana free of viral hepatitis as a public health problem. The objectives were to prevent the transmission of viral hepatitis, to establish an effective surveillance system, produce guidelines and protocols for the diagnosis and management, and we managed to publish hepatitis B and C guidelines in about 2017, 2018. Promote research, promote safe, effective, and affordable diagnostic and testing and treatment, still a mirage, and foster good relationship or partnership between key stakeholders, including associations like yours. I must say that so far there have been significant or greater obstacles to achieving these goals. There's a huge information gap. I have just shown you maps that show gaps in the data. I mean, if you go to everywhere, most parts of this country, they're checking hepatitis B and sometimes C in all pregnant women, but nobody's reporting the data. And so really, we don't know the true prevalence of hepatitis B and C in the country. And these are all what I've shared with you are meta-analysis or forecasts. Yes, there's a HEAT project going on, which is trying to define this in a better, give us a better prevalence. Hope that would work. Okay, so we need to update our national data. One major way of preventing hepatitis B, especially, is to prevent the mother-to-child transmission. And that is by giving a vaccine to the newborn babies, not just of the positive mothers, but of every child that is born in an environment like Ghana where hepatitis B is endemic. Unfortunately, that birth dose vaccine is still not part of our vaccination protocol. So we are vaccinating people 6 weeks after birth. And by that time, if we're going to get the infection, many people would have had it. And so the horse would have bolted before we are vaccinating them. They would have had the infection already. I mean, there's no clear policy on at-risk groups. You know, at least if you work, in fact, in Ghana, because the virus is endemic, everybody should be vaccinated. If not, at least the high-risk group persons, like health workers, must be vaccinated. But there's no clear-cut policy. You can be a health worker, and if you don't make your own effort to get vaccinated, then it's you're on your own. Okay, so again, that's a gap. I can imagine what the uproar that will come if Ghana decides that they're going to give people who use IV drugs free needles to prevent hepatitis C transmission. We'll fight it like anything, like we are fighting the LGBTQ thing. So again, that's something that is militating against the prevention. Testing is a problem. Yes, these days you get, and tomorrow GASLIDD and many other organizations are screening people for hepatitis all over the world, the country. But otherwise, on a regular day, pregnant women, everybody has to pay for hepatitis B and C testing out of pocket. If they are positive, the subsequent testing for the viral load, the liver test are all borne out of pocket. Never mind that if you look at the NHIS list, you would find hepatitis B and C there. Nobody can do anything for you if you just test positive for hepatitis B. The subsequent testings are important in making decisions on whether how they should be treated. But again, you have to pay out of pocket. The treatment is another problem. because, I mean, and that's one thing I'll be speaking to forcefully in Ho tomorrow. You would not, I mean, many people pretend they can treat hepatitis. Unfortunately, not many people even know how to interpret the results of the hepatitis profile and the subsequent testing. So somebody sees a few negatives, like say E antigen negative, and the interpretation is that the person is does not need treatment. They should go, and if you like, sin no more until we see them with bad complications. So these are, and of course, the treatment, you have to pay for it. So these are gaps that, unless they are addressed, all our efforts to achieve hepatitis elimination will come to naught. So these challenges that I have shared with you are not just unique to Ghana. They are global. It is a global data. They are prevalent even globally. So for both of the 300 plus million people that are infected with hepatitis B, only 12% have been diagnosed. And only less than 2% are on treatment or have been treated, which means that there's a huge gap that we have to fill. And this is what we all should be doing on a daily basis, but on a more important, a day dedicated to hepatitis, like the World Hepatitis Day. So we have to adopt a new strategy. At the policy level, we need to increase advocacy and resource mobilization. We have to update our treatment guidelines. So our treatment guidelines are becoming like approaching a decade since it was published, and I have not seen any movement in trying to update it. We definitely need to strengthen the surveillance. I told you, many people are checking hepatitis. So sometimes when I hear the hepatitis data that is published, I smile because I know that is much more than it's being reported. Definitely we need research, because I have told people, if hepatitis B, for example, was prevalent in Europe and the US like it is in Africa and Asia, they would have found treatment just like they have found treatment for hepatitis C. I've told you about the gap in vaccination, and so we need to upscale vaccination. Definitely, we need to improve screening, care, and treatment to infected persons. So we need a better, and if you like, better collaboration between persons who manage hepatitis B and C. Now we need to rethink our treatment criteria at a clinician level. So presently, if you have hepatitis B, not everybody is treated. We would look at your liver test, your viral load, your ultrasound, whether it's suggestive of cirrhosis or significant damage to the liver or not, and decide that we should treat, whether to start treating you or not. For all persons who do not meet these criteria, we just follow them up. But then, personally, I've seen that if a person keeps coming to the clinic 3-4 years, we haven't put them on treatment, they get discouraged and they're lost to follow up. So the question I ask myself is, why don't we treat everybody with hepatitis? Why don't we begin to treat everybody with hepatitis who is hepatitis B positive? Because we have history to guide us. Many years ago, if you were HIV positive, we would check your viral load or check your CD4 count, and if it was above a certain level, we wouldn't treat you, but now we are wiser. Once you are HIV positive, we should begin to, we start treating you. So I have been advocating strongly that judging by the number of deaths we are getting from hepatitis B and C, or hepatitis B, it probably will make more sense to start treating everybody, because the person in my hometown does not have access to a physician or a gastroenterologist, and so would never have anybody look at this and say you need treatment. And that is a challenge in our current guidelines. For hepatitis C, yes, everybody should. I would ask for 2 seconds to do something, please. Okay, let me come out and please. Okay. I'm really sorry, because I was thinking I would give a lecture later, so I didn't really prepare. Okay, so forgive me. Yeah, so for hepatitis C, if you're hepatitis C positive, we have to do some subsequent testing, the viral load to say that you have active infection. But also we try to do a genotype testing to decide which drugs to give to you. Yes, that's great, but there are drugs that can treat any genotype. So again, as clinicians, we need to begin to look at must we still continue to do genotype testing? Why don't we treat everybody who has hepatitis C, who has detectable viral load, just treat them with pan-genotypic drugs than imposing more costs for them to check their genotype. Now, if you have hepatitis, I say you need to take control of your life. If you have hepatitis B, know that the lack of symptoms is not equal to the lack of danger. I told you the persons who have chronic hepatitis B do not have symptoms, but they end up developing complications. Get educated and know that treatment is available. It's not true that hepatitis B cannot be treated. It can be treated. Of course, treatment is long-term. Get professional help and keep your appointments. Many people get fed up along the line. Unfortunately, they won't have any symptoms, and then 5 years later, they've developed liver cancer. I say hepatitis B, if you have it, the first time you get any symptoms or signs, it's too late. You are on your way. And if you have hepatitis B and you are put on treatment, please take your treatment for as long as it is recommended, because the treatment will not cure you. So don't go do a viral load or a liver test and say it's normal and so go off your treatment. If you have hepatitis C, I have good news for you. There is free treatment. Remember I said that these drugs used to cost about $60,000 to $90,000. It's available for free now in Ghana. And you can get cured after just 12 weeks of treatment. So if you are hepatitis C positive, please see your doctor quickly, because this offer won't last forever. But if you don't have hepatitis, I say stay safe. And how can you stay safe? Get vaccination, because there's vaccine to prevent hepatitis B. And when you start the vaccination, be sure to complete the 3-dose schedule, because you need 3 doses to have immunity. And if you're at high risk after the vaccination, you're a health worker, you work in the lab or something, check your antibody titers to be sure that you are safe. Booster doses are not mandatory unless you find out that your titers are falling. Even if you are vaccinated, still avoid risky behaviors, so that even though I've said that sexual transmission is low, you still should know that the risk is available. And if you are free from hepatitis C, don't share needles. Avoid contact with contaminated blood. When you go to the barber, shine your eyes. Make sure that they are using new blade for you. And check up on, if you're going to get a tattoo, make sure that they're using new equipment. Hepatitis C transmission through sexual means is low, but it's still possible. And definitely, you won't do LGBTQ plus stuff, because that definitely increases your risk to hepatitis C. Now, to protect our liver, the liver is important, so we must protect it. And the various ways to protect your livers are that you should know your hepatitis status and seek treatment. Reduce alcohol intake, because that then puts your liver at double risk, even if you have hepatitis, any of the hepatitis. Obesity is a challenge, because it also affects the liver, causes fatty liver, that causes a problem. Hypertension and diabetes also have negative impacts on our liver. So all these will have a negative impact. And if that happens, it means we can't live longer and we won't be available to protect our loved ones. And definitely without the liver, all your other organs are at risk. So please let's show gratitude to our livers by protecting the liver. Now I want to introduce you to GASLIDD, which was the other thing I was asked to do. Basically, GASLIDD is an association of health professionals who have interest in liver and digestive diseases in Ghana. It was founded in February 2011, and I was the foundation general secretary. Our aim, essentially, two of our important aims are to exchange ideas and knowledge about liver and digestive diseases and promote the advancement of health and allied sciences in this field. Now, on the World Hepatitis Day, what we do is to create awareness, screening, and advocacy. And so in the various regions, in the various teaching hospitals, and even at the national level, they are organizing programs to meet these awareness creation, screening, and advocacy aims. Now, for you as public health students, I say there's an opportunity to become members, or if you like, associate members of GASLIDD, because associate membership is open to all medical and allied trainee scientists, postgraduates who are in postgraduate training in the fields of hepatology and gastroenterology in Ghana. Unfortunately, we don't have a website that I can direct you to, but you can contact the current General Secretary, Dr. Amakudia, who is at University of Ghana Medical Center, and his phone number is shown there. So if you send him a WhatsApp, he will share the application forms with you, and then you can enroll to become a member. As an association, you can join the fight in creating an health awareness about hepatitis. And I always say this, that once upon a time, I saw somebody, a professor of HIV, and he had liver cancer from hepatitis B. And when I told him, he said, "Oh, doc, why don't you people make noise about this? You know, I don't know about this. This is a professor of HIV. He had not heard about hepatitis." All right. Another time I tell somebody, "You have hepatitis." They said, "What? I have hypertension?" Oh, because really there's a real, so we need to create more awareness. All right. You can take up screening and testing initiatives in the very places that you school or work. You can promote vaccination and other preventive measures. If you are well resourced, you can provide support for individuals, advocacy and lobbying. But importantly, if you can raise funds, then you will be able to achieve these objectives. And if there are any of your faculty online, I think that is great if they can incorporate hepatitis awareness into your curriculum. Now, so my 5 key messages, that the liver is important, so let's protect it. Hepatitis is common and a killer. Hepatitis infections and deaths are preventable. Our actions towards 2030 elimination, hepatitis elimination, are lagging behind. Let's stop the NATO. Okay, no action, talk only, and start more. All right, let's play our part. How? So you've only got one liver, and you've only got one life, and you've got only one liver. But hepatitis can devastate both. Protect your liver, protect your life and that of your loved ones. I can't wait, so don't wait. Let's act together for hepatitis-free Ghana and world by 2030. Thank you very much.
Okay, thank you very much, Doug. Yes, one thing that I heard was that we should stop the NATO, no action, talk only. I mean, it is high time we educated about hepatitis B. I mean, the different types of hepatitis you've spoken about, because there's a need for people to know more about hepatitis B and stop the stigma and discrimination. We are so grateful to you. Yes, so the next speaker on our list is Dr. Atsu Godwin Seake-Kwawu. Yes, Dr. Atsu Godwin Seake-Kwawu graduated. He took up the mantle of program manager at the National Viral Hepatitis Control Program in the Public Health Division of the Ghana Health Service in June 2020. He graduated from the University of Ghana Medical School, after which he pursued postgraduate studies and holds a Master of Public Health degree, as well as other postgraduate certifications from reputable institutions within and outside Ghana. He is a member of the Ghana College of Physicians and Surgeons, Faculty of Public Health. And prior to joining the program, he had worked in both medical and public health practice at the district level. His joy is to see viral hepatitis eliminated in Ghana. So without much ado, I would like to call upon Dr. Atsu Godwin Seake-Kwawu to also give us some insight on hepatitis and the policies that have been put in place to eliminate it. So, Doc, please, if you are on, please, you can share your screen and then start presenting.
Yeah, thank you very much. Can you hear me?
Yes, please, I can hear
Yeah,
you.
allow me to share my screen, please. Have you given me permission, please?
And please, what's your username?
Yeah, no, go for it. Yes. So finish.
My username is my name, as you put it out. I don't know where you can get me.
I've done that already. You can share your screen now.
I can share this.
Please,
Okay.
yes, you can.
All right. Okay. Okay. Yeah. Good evening, colleagues. I hope you can see the screen. Can you all see the screen, please?
Yes, please.
All right. I want to
Please.
I wanted to do the slideshow. Let me see how it comes. Okay. Okay. All right. Now we are there. Yes. I'm glad to have to do this presentation after the very spirited advocacy by Dr. Tachi. So, Dr. Tachi, good afternoon. Good evening. We'll find time and sit down and see where we can take hepatitis forward. I've seen some powerful articles you wrote in the Lancet, and they are always sources of encouragement. So you asked me to talk about policies implemented by the Ghana Health Service. I put it as policies adopted. I would explain why, and then I'll put also in perspective the role of public health students in realizing the ends of policy. So this is the presentation outline very briefly. Dr. Tachi has touched on a number of things that I would not touch on at all. I will just jump over them. But this is the outline of the presentation. Key for me is how and where public health students fit in. So he's talked about this. Yes, he addressed this. Except let me say that the vaccine for hepatitis E from 2024 is likely to receive approval by Gavi. So it will only be left to hepatitis C that will have no vaccine. The chronic sequelae he talked about, and this is what we have to avoid by early detection, early treatment. It's key because too many people are dying in the prime of their lives. I can remember a young man on the medical ward who came with liver complications related to this. In the last days, he was just sharing his money to anybody who came across because there was no use for it at that point. So we need to avoid getting to chronic hepatitis, cirrhosis, and end-stage liver disease or hepatocellular carcinoma. Now, about the disease burden, I take it that you are students, so we need to just look at it. Let's look at the Ghana picture. In the HEAT study, the prevalence of hepatitis B was established at 11.4%. That was done in 2021, pulling data from 2015. 2015 down to 2020 thereabouts. We must understand that this was based on in-hospital testing data. That's the data in the laboratory registers and so on. They were put together to give a picture of what is happening and not necessarily to give us the national seroprevalence data, which is who have been done with a different methodology altogether. And for hepatitis C, the researcher estimated 4.58%. Now, we also have, apart from these field studies, we have modeling. We have modeling, which is done from time to time to be able to estimate the burden of the disease. And in 2019, the estimate was 9.1%, and then 3.3% for hepatitis C. The figure of 8.36 was shown by Dr. Tachi was based upon the meta-analysis of people 20 years and older. So it didn't cover all the various ages. That was done by these guys. I didn't cover all the age group, but somehow all these figures, what they tell us is that hepatitis is a big problem in Ghana. And because with a prevalence more than 8%, consistent by various methods with all their inadequacies, it is clear that Ghana is hyper-endemic. And when a country is hyper-endemic, it means that transmission is driven by mother-to-child transmission, not just sexual transmission. So when you look at the models over the years, taking all ages prevalence from 1990 to 2019, you can see a falling prevalence for all ages and under 5 prevalence due to immunization. Because the timely introduction of hepatitis as part of pentavalent vaccine in 2002 has been very beneficial and keeping the burden low, but it could have done better if there was a birth dose to close the gap between birth and 6 weeks. And also, of course, if people are not missing out there on their doses. So you've seen this map already. Last year, we had an estimation of the risk of mother-to-child transmission in Ghana. This study was supported by CDC. It's not yet completed, but we have the phase one results. That shows us that among pregnant women sampled from 55 antenatal sites across Ghana, these were the various percentages that were positive for hepatitis B, with a national prevalence of 8.7%, which is worrying and calls for immediate action. So Ghana has to act because under the SDGs, there is the need to achieve universal coverage for everybody, including those with hepatitis. Those who are not covered, those who are not receiving all services, and those who are paying catastrophic fees to receive services. All these things need to be addressed. So we have a mandate under the SDGs. SDG Goal 3 is to ensure healthy lives and promote well-being for all at all ages. And target 3.3 under this is to combat hepatitis. I put it in green. So it has an indicator of hepatitis B incidence. That's new cases per 100,000. This will be used to measure achievement in this direction. And WHO came up with 2 major strategic documents towards elimination. The first one is the Global Health Sector Strategy 2016 to 2021 towards ending viral hepatitis. It's a great book, and I think it's worth accessing online by those who are interested, you could look at it because it's quite educational. It can educate us a lot. Then last year, there was the elaboration of the integrated strategies on HIV, hepatitis, and STIs for 2022 to 2030, recognizing, sorry for the duplication, recognizing the fact that there are commonalities and individualities between HIV and hepatitis. So this strategy seeks to take advantage of the commonalities and see how could address them using existing funding mechanisms. Global Fund was put in place to address HIV. The mandate was not covering hepatitis. But with the growing hepatitis problem, there was the need to make sure that what could be done under the HIV mandate with Global Fund can be done. Hence, this new strategy has been put out. Now, organizing hepatitis services towards elimination requires a comprehensive public health approach, where prevention of infection and disease are prioritized, health promotion is prioritized, prolonging of, just a minute, prolonging of life, access to quality services for those most in need, offering of simple and standardized set of interventions and services to those who need it through a decentralized offer that can be taken to scale to cover every part of this country, addressing equity and promoting gender equality, making sure communities are engaged, including those who have the disease, and not leaving them out. They have critical inputs to make into decision making. And also leveraging public and private sector responses so that we could have a well-coordinated way forward to control or eliminate the disease. So Ghana outlawed this national policy in 2014 with a vision of Ghana. What's happening here? With a vision of Ghana free of viral hepatitis as a public health problem. And the mission is to have effective surveillance, prevention, and control measures, and supported with relevant research. The goal covers all the hepatitis, and we know that with elimination goal in sight, B and C are very, very critical. So we have the policy objectives and the strategies, as you can see, prevention of transmission all the way through fostering partnerships. Now we look at the various policy areas because they give us a direction, some mandates that have to be delivered. Under surveillance and response, we to establish a hepatitis surveillance system capable of detection, confirming, and management of all hepatitis and responding to outbreaks. Then under laboratory diagnosis is to establish a comprehensive and accessible laboratory service that is capable of detection and characterization of all the types of viral hepatitis. Prevention is to establish a system to protect the at-risk population in Ghana through vaccination, screening of at-risk population, and prevention in healthcare settings. We have advocacy, which aims at having a well-informed public capable of making informed decisions on viral hepatitis. Then treatment, care, and support, access to safe and affordable diagnostics and treatment to ensure comprehensive care for all. Research, it's also here, research that answers to the needs of the country to provide evidence to respond to the disease burden. Then regulation is there, the need to comply with all the regulations, including those of FDA. Then implementation is there, monitoring and evaluation, and then resource mobilization. And when you look at implementation, that's
Excuse me, sir,
policy.
please.
Hello?
Can we see your screen, sir? Your screen. We can't see your screen.
You
Sir.
can't see the screen? What's happening?
Yes, sir. We can.
Yes, sir.
Oh, sorry, you could have drawn my attention much earlier because I see. Okay, so I'll try to share again. Because okay, I'll. Is it okay now?
Yeah.
Oh, sorry. You didn't miss much. Now that I've done this, moving the slides is becoming a problem.
Just put your cursor on the slide and hit it, it will move.
Oh, it will move, okay. Oh, okay. Thank you. So, those who did not see the screens earlier, I think talking about organizing the services using the public health approach is key to elimination. If we don't use this, we may not be able to eliminate hepatitis. And we also look at the policy, the vision, the mission, and the goal, then the objectives, then the various areas of policy and the directions that they give. Surveillance and response, laboratory diagnosis, prevention of viral hepatitis, advocacy and social mobilization, treatment, care and support, research, regulation, implementation. Implementation of policy is supposed to be done through a national health strategic plan. This is what my colleague said he didn't see in what the coalition put up, and that is very true. That is very, very true. Monitoring and evaluation, and then resource mobilization. These are key things within the policy areas that have to be addressed. And there's a lot of linkage between these because without resource mobilization, it's difficult to implement any of these things. And without the strategic plan, you cannot easily mobilize resources. So all these are very important and interdependent. What are the core intervention areas for hepatitis? Vaccine is there. Prevention of mother-to-child transmission is there. Infection prevention is there. Harm reduction for people who use drugs, and the sterile syringe and needle component is also there, and then effective treatment. These are all key interventions for viral hepatitis, and these have been defined in the Global Health Sector Strategy. So how can public health students fit in? This is the question I had to deliberate on because I realized that public health students come from diverse disciplines. They bring in a wide knowledge base and with interdisciplinary skills. They're learning epidemiology and related courses, acquiring research skills. Some may have skills in advocacy, social mobilization, and ICT. And so how can they fit into and make sure that the policy mandates are delivered? Now, reflecting a bit on my association with hepatitis over the last few years, I can say that there is the need to have additional skill sets that are more or less focused on what hepatitis issues are, so that we'll be able to function more effectively as public health students. We need to understand that viral hepatitis awareness is very low among health workers in Ghana. In fact, not only in Ghana, it's across Africa. And the awareness is even lower within the population, because if the health workers do not have good awareness, population will also not have it. We also need to have a basic understanding of the viral hepatitis B and C core subject matter. The complexities may be left to the subject expert, but the core subject matter as an infectious disease is something that as public health students we need to have. And we need to pay a lot of attention to hepatitis B and C and the basic difference between them, so that we can spot where things are wrong. I went to a place in northern Ghana where there was a signboard advertising vaccination for hepatitis C, which is actually misleading everybody. We need to be able to understand the epidemiological or the disease model, the various stages from somebody who is well, so you are dying from hepatocellular carcinoma or end-stage liver disease. What are the processes and what are the factors that influence each stage of it? Having that understanding will be key and as a tool to enable us function within hepatitis. Also, we need to update our knowledge in this field, which is rapidly changing. There's a publication called Hepatology, which is revised, I think, almost every 2 years. The last one, there's a lot of information in it. The last one I came across, Hepatology 2020, I believe maybe by this time there are other revisions of it, but it contains a lot of up-to-date information in this rapidly changing field of knowledge. And we need to be conversant with the serological profiles of B and to be able to interpret it, because many times this is where we get it wrong. Like Doc said, Y antigen is negative, so it's like, oh, you don't have a problem. When in actual fact, when you get the subject matter, you realize that it ought not to be so, because there are some people who, though they are negative, they go on and develop hepatocellular carcinoma. Then we also need to understand hepatitis C testing results and its implications. Many people are holding hepatitis C positive results in hand, and people are being treated on the basis of rapid diagnostic test kit results, which is really not what should have been. So we need to understand how to arrive at the fact that somebody has hepatitis C. It is key. Then, of course, we need to be able to operate hepatitis surveillance system and applying the various case definitions. One of the big difficulties we have in Ghana here is data reporting. From the village all the way down to the teaching hospitals, especially the teaching hospitals that see the bulk of cases and manage them. Their report does not end up in the DIMS where the national repository is assessed. So always you are looking at a partial picture. People are being tested for antenatal for hepatitis B, but you realize that these are being done by people who have sourced kits privately and they are using it for their 5CD. Meanwhile, the issue of whether you have hepatitis B in pregnancy is a critical issue, and you need high quality tests to do this. But because people do this, there's no recording. It is something that also needs to improve. We need to do a lot of work on the surveillance system, apart from the general paucity of knowledge, because you just cannot fill in hepatitis data set if you don't understand the subject matter. It is very key to really make sure that this understanding is there. Then, of course, understanding the place of vaccination in hepatitis B and the various schedules. We've talked about health dose already, which if things go well, Ghana may implement coming 2024. Yes, we also know where There have been discussions on whether there is need for booster doses and so on and so forth. But the understanding is actually that booster dose is not really required. There are also people who are non-responders to vaccines. These non-responders need to be identified, particularly those in the healthcare system. We need to identify them so that when they are exposed, something can be done for them very quickly. Otherwise, they are also at risk. Then, of course, managing of community screening programs. Again, without a proper testing policy in place and the various algorithms that can be used to arrive at somebody is infected or not infected, it is very, very difficult to be able to go on scale in large scale screening, whereby false positives and false negatives become issues of very much concern at that scale. So it is important to understand the issues around screening very well. And of course, community mobilization is key. Countries that have implemented hepatitis B birth dose, like Nigeria, for instance, coverage within the first 24 hours is very, very low. But for effective coverage, it must be within the first 24 hours of delivery. So what it means is that there's a lot of work to do around mobilizing communities to understand why the children need to be given birth dose and making sure that the midwives also get it done, or those who go to immunize in the house also get it done. And of course, acquiring research skills to answer the nagging questions. For example, why do we have so much more hepatitis in the north than in the south? Can we have some analytic studies that look at this scientifically instead of we all thinking maybe it is because of this or because of that? Certain things may look obvious, but when they are established research-wise, then of course, we all have strong backing to move on. Then, of course, once you are dealing with hepatitis, you come with the issue of drugs and stigmatization, where criminalization and things all come in. These are areas that require advocacy to get a good response to interventions. There has always been the fear that you could be distributing free sterile syringe and needle to somebody who is injecting drugs, and police will come and arrest you. Yes, these are all issues that require common understanding in the institutions that work in that area. Then, of course, we need relational skills for multi-actor coordination, because hepatitis has so many different actors. The NGOs are there, the gastroenterologist community is there, and there are people whose work directly impacts on what is achieved in hepatitis one way or the other. So we need to be able to deal with this. Then, of course, we need to understand the program indicators, the data management, including the whole issue of registry management, because with that, if we had a good registry in this country, data on all people diagnosed anywhere with hepatitis B will be there. But unfortunately, there's no national registry. Then, of course, we need to be able to communicate in simple terms so that people would understand what we are talking about. My observation is, by the time we have presented HBsAg, we've lost a number of people because they see the complexity in the writing instead of understanding that, oh, these are people who are positive for hepatitis B. So we need to learn how to communicate hepatitis in simple terms for our stakeholders to understand it and be able to take the required actions. Also, of course, we need to be able to coordinate interventions at national, subnational level, direct involvement with treatment and care. Some of you may have laboratory backgrounds, and of course, ability to translate complex information to easy to follow formats so that it can be used at the decentralized levels of the health system. Otherwise, we'll talk above the head of everybody. Meanwhile, that's where the majority of people are. So you can fit into the area of surveillance and response, including laboratory surveillance, behavior change, communication, advocacy, social mobilization, coalition building, and demand creation. Demand creation is key. Having services available, people are not using it, is not the best. So demand creation is key. Specific prevention like vaccination and the infection prevention, all these areas are areas that can be promoted, awareness created around them. Training and research, they are also key. Resource mobilization, program coordination, M&E. These are all areas where I think that as public health students, we can fit depending upon our interests. So in conclusion, what I say is public health training equips you to function. But in view of the low awareness, basic core subject matter knowledge is critical. And there are many roles that you can fit in depending upon the stage of evolution of the program. And whatever the role, effective functioning is required if we are to eliminate viral hepatitis. Thank you very much for your attention. I'm available for any questions. Thank you.
Yeah, thank you very much, Doc. And we would like to ask if there are any questions for him so that we can move on to the next speaker. Okay, then we quickly move on to the next speaker. The next speaker is our own father, Professor Joseph Humphrey Kofi Bonney. He's holding his PhD, MSc, and BSc. J.H. Kofi Bonney is an associate professor of virology at the Noguchi Memorial Institute for Medical Research, University of Ghana. His current research focus on emerging and re-emerging infection, particularly viral zoonosis, including viral hemorrhage, fevers such as Ebola, Lassa fever, and Rift Valley, and arboviruses. Work emphasis on study viruses interactions from molecular to population level. The aim is to enhance biomedical research on emerging and re-emerging infections and build preparedness for both basic and applied research, focusing on developing new diagnostic methods and investigating the epidemiology at molecular and population levels for viral diseases, including hepatitis and respiratory tract infections. Prof. Bonney has supervised and co-supervised close to 41 undergraduate and postgraduate level thesis and examined master's and PhD level thesis.
Hello, Doc.
At the University of Ghana.
Hello, Doc.
Yeah, hello?
Can we see your screen?
Well, I am now introducing the professor who is here to speak.
Okay.
Professor Joseph Humphrey Bonney. So, Professor, among others, he is a member of the following societies and groups: Society for General Microbiology, UK, American Society for Microbiology, the Royal Society of Tropical Medicine and Hygiene, UK, American Society for Tropical Medicine and Hygiene, member ECOWAS Regional Rapid Response Team on Pandemic and Emerging Infectious Diseases, member National Technical Coordinating Council on Pandemic and Emerging Infectious Disease. He has been invited and attended over 45 prestigious national and international conferences and workshops where he often plays key roles, presented papers, posters, and research funding. He has 61 published research work in referred journals. He is married with 2 kids. Help me welcome our next presenter, Professor Joseph Humphrey Kofi Bonney. Professor Kofi Bonney, your audience, Professor. Please, Professor, you may proceed to present.
Thank you very much. Thank you very much, Mr. Is it the MC, the Master of Ceremonies? Thank you for the nice introduction. Can you please allow me to share my screen then? Thank you.
That is done already.
Prof, you may proceed to share your screen.
Yes, you can share your screen now, sir.
Yes, we will do it. We will do it. Oh, it doesn't. No, we will do it. It doesn't have to be. We usually do it in August, September, those times. I have not even applied. I have not even applied yet. But we will do it.
Hello, please, can you see my screen?
It goes beyond a day.
Yes, please.
Yes, sir.
Yes,
we can see.
Right, so thank you very much. And I am very grateful for the opportunity. And also I have to apologize that I couldn't present earlier as scheduled on your program. I have to come in from Kumasi and I just arrived a while ago. Right, so I'm going to go through just the introduction, which my previous speakers have done a very good job on that. So I will not spend too much time on it. I will talk a little bit about the epidemiologic determinants of hepatitis B. I will more or less concentrate on hepatitis B, talk a little bit on the transmission, then prevention and treatment. I will mention a bit on vaccines, then some of the research work that we've done over the last decade on viral hepatitis too. I'll share that with you. Thank you. So, for viral hepatitis, it has clearly been defined by my previous speakers. But let me just reemphasize that it is a systemic disease with primary inflammation, the liver, by any one of the heterogeneous group of hepatotropic viruses. These are hepatotropic viruses because they are viruses that have an affinity for the hepatocytes, in other words, liver cells. And these viruses include hepatitis A through to hepatitis.
That's okay, Monaco.
In addition to the nominal hepatitis viruses that we've mentioned, that is the viral hepatitis A through to E, we also have other viruses that can cause liver inflammation. And I'm talking about viruses because I always speak on that end. I'm a virologist, so I talk about viruses. There could be other pathogens, that is disease-causing agents, that can have a burden on the liver, that I will concentrate on the viruses. So we can talk about herpes simplex, cytomegalovirus, Epstein-Barr, and even yellow fever. All these have got some kind of burden on the liver. If you look at the historical perspectives, yes, we can group them into the A, B, C, D, E, but we usually, or at first, we used to call the A and the E's as the infectious hepatitis because they technically cause acute infections. Then we look at the B, D, and the C, or let's say B, D, an innate virus. So the B and the C as serum hepatitis. Interestingly, we have gene there. Sometimes we call it hepatitis G virus or the GB virus C. And this is rare, but it has been documented to have viremia, and also there is no evidence historically that gene has been causing has been established. No historical evidence has been established. But interestingly, it's a virus that belongs to a family of viruses that we call them flaviviruses. And if you look at the sequence, analyze the sequences that we have for hepatitis G, it is about 27% close to what we call hepatitis C. That is, has a 27% homology to hepatitis C. So it's a very interesting virus. That more research currently is being done on this particular virus, which also has got or causes an inflammation in the liver. Right. So if you look at this table, I think bits and pieces of it has been shared already. So maybe I'll just look at some of the interesting points that we have in here and talk about it. If we're looking clearly about the age that these viruses affect, you can see that for hepatitis B, which is my main focus of discussion for today, a cut across all ages. It is not respecter of any age group. Anybody at all can have hepatitis B.
But
So if you look at the B itself, the definitions has been established already. It is transmitted by the parenteral route. We know that the acute illness causes liver inflammation, vomiting, jaundice. Yes, we talk about rarely death, but we know that chronic hepatitis B may eventually cause cirrhosis and liver cancer, hepatocellular carcinoma. But here, what is important here is that hepatitis B is endemic. In fact, if we talk about in country, it is hyper-endemic. And it's endemic throughout the world, especially in tropical and developing countries. And if you look at this map that we have here, you can see that across the globe, everywhere, this is even chronic hepatitis B prevalence. Everywhere in the world, yes, though we have some areas where the prevalence is low, under 2%, but then it has been established every part of the world that we have hepatitis B prevailing there, which is interesting. Now, let's look at some of the epidemiologic determinants. We look at the agent itself, the hepatitis B virus. We know viruses are particles. And so this actually is a complex, which is close to about 42 nanometers. And is a double-shelled DNA virus, originally called the Dane particle. And like I said, viruses are particles. So this Dane particle is what was originally the name of hepatitis B, the virus, the structure. I will look at it very soon. And of course, it replicates in the liver. In other words, the liver cells have a very strong affinity for these viruses. So when they get in there, that is where they propagate and come out with their progeny, and they affect other cells. In other words, they proliferate within the liver. If you look at the hepatitis B itself, it occurs in 3 morphological forms in the serum. So we have small spherical particles with an average diameter of about 22 nanometers. Then we can also have the filamentous or the tubules. And that one, the length varies, and mostly around 22, but we can have smaller sizes and all that. Then the Dane particle itself. So out of the 3 morphological forms, it's only the Dane particle that is considered infectious. In other words, if we say it's infectious, that is the viable virus or the virion that when you get exposed to it and it gets to the right cell, certainly there is going to be replication. So when we talk about the Dane particle, that is the infectious particle. And if you look at the structure very well, this is what we call the Dane. That's the complete particle. So that is what we call, if you look at the structure carefully, yes, it is an enveloped virus. So we have an envelope there. Then we have the genetic material being a DNA. So viruses can either come in RNA or DNA. There's no virus that has got both nucleic acids. So this is a DNA virus. But even with that, you can see that though it's double-stranded, we have partial single strands within the nucleic acid, or as part of the nucleic acid. Then you can see clearly the surface antigen. And also the E antigen is there. We have the core antigen too is there. These are agents that are very key, markers that we look out for when we are doing, or when we develop assays in testing hepatitis B. Still on the epidemiologic factors, if you look at the reservoir of infection, we talk about men as us. I'm talking about us as human, the only reservoir of infection, and it can spread either from carriers or from cases. Looking at the infective material, can be contaminated blood is the main source. So the virus can be found in body secretions such as saliva, vaginal secretions, semen, that is in infected material. Then we talk about resistance. These viruses can be destroyed by, hypochlorite solutions, if we talk about the normal bleach that we have. And also we can heat sterilize it. If we heat it above temperatures, anything above 30 degrees to around 60 degrees will inactivate the particle. So that means it becomes inactivated and it will not be infectious at that point. When you look at the host factors, we can look at the age, both for acute hepatitis B and also chronic hepatitis B. And you look at the figures in there, about 90%, if we talk about acute hepatitis B, 90% resolve by themselves. And for chronic, 2 to 10% will progress to chronicity. And we have the perinatal, the childhood, and after 5 years also established them. If you look at the risk groups, yes, I think the previous speakers, I think Dr. Tachi did mention it. The people from endemic regions, and if we say endemic regions, even though the virus has been detected or is found across the globe, we have areas that are clearly being marked as endemic areas. In other words, these viruses are seen there all the time. They see them, they dominate. They are all over. So they see it more than it being either sporadic occurrences or once a while. They are found in a lot of people within these areas. So they are endemic regions. So people from these endemic regions are one of the higher risk groups. We can talk about babies of mothers with chronic hepatitis B. That one too, I think my previous speakers spoke a lot about it. Intravenous drug users, people with multiple sex partners. We can also talk about hemophiliacs and other patients who say this is requiring blood and other blood product treatment. Healthcare personnel who have contact with blood, and that is who are not in the proper attire. That is, we talk about the personal protective equipment. If they are not properly attired, then they can get exposed. And if there's any broken skin, or if it is a point that they can infect themselves, if you get exposed to an infected blood, then the chances of you infecting yourself becomes high. We can also talk about patients who are immunocompromised. Then looking at the humoral and the cellular response, it occurs in 3 distinct antigens. So we can talk about the surface antigen, the core antigen, and the E antigen. But they stimulate production of corresponding antibodies. So that is a good thing. So briefly on the mode of transmission, we can have the parenteral form, that's the IV drug users, and the health workers. Like I said in the previous slide, they are most at risk. Sexual, So sex workers and homosexuals are particularly at risk. Then if you talk about perinatal, then here vertical transmission, which has also been spoken about at length, is also another, that is one of the easier ways of people getting it. The serologic events, if you talk about surface antigen, it is the first marker to appear in the blood. That is after one is infected. And when we talk about infection, we shouldn't confuse it with just exposure. Infection is when the virus enters the cell and starts the replication. So that's infection. And the first marker is the surface antigen. And we can also talk about the surface antibodies. So disappearance of the surface antigen and the appearance of the antibodies signals recovery from hepatitis B infection. It doesn't mean non-infectivity. So we can also have the anti-hepatitis B core, that is IgM anti-hepatitis B core, appear shortly after surface antigen is detected. We can talk about the IgM, or may also or can persist for 3 to 6 months or longer. We also talk about the IgG, the core, also appear during acute hepatitis B, but persist indefinitely. The E antigen appear in the blood concurrently with the surface antigen. It can also, is also a soluble protein found only in positive serum, those who have the E antigen. And the persistence of the E antigen in serum beyond 3 months certainly indicates an increase in the likelihood of chronic hepatitis B. If we talk about prevention, mainly vaccination, highly effective recombinant vaccines are available. We also talk about the age big, exposed within 48 hours of an incident, or neonates whose mothers have the surface antigen. If they are given the immunoglobulin B, then that will suffice. We can also have other measures in screening of blood donors or body fluid precautions. Taking precautions against being exposed to body fluid. Treatment, yes, interferon alpha response rate is around 30 to 40%. Lamivudine, we can also talk about what we call the Hepzera. Chronic hepatitis B treatment, basically the goal for that is suppression of HBV DNA to undetectable level. We can talk about normalization of ALT or AST, improvement in liver histology, loss of E antigen, reduction of either clinical progression or reduction of hepatic decompensation and death as well. So that is the goal of the treatment. Then if you talk about indications of treatment, this is mainly based on certain criteria. That is 3 of them: serum HBV DNA levels, serum ALT levels, and also severity of of liver disease. Patients should be considered for treatment when they have HBV DNA levels above, we're talking about our 2000 IU per mil. The serum ALT levels above the upper limit of normal. That is, if a patient is having that level, is having serum ALT levels above the upper limit, the patient should also be considered for treatment. Then also we can talk about severity of liver disease assessed by the liver biopsy. I think Dr. Tachi mentioned something like that. If we talk about patients with cirrhosis, treatment should be started as soon as possible. So if it is not detected, and when it was detected, the patient is already having cirrhosis, antiviral treatment is indicated, irrespective of the HBV DNA level. So clinical studies indicate that prolonged and adequate progression and suppression of HBV DNA can stabilize patients and prevent the progression to decompensated level liver disease. Regression of fibrosis and even reversal of cirrhosis have been reported in patients with prolonged suppression of viral replication. So this means that irrespective of the HBV DNA level, treatment should be started as soon as possible if a patient is seen to be having cirrhosis. Then the strategies currently are either you treat with finite duration with a PEG-IFN, that is interferon, or long-term treatment with what we call the nucleoside or the nucleotide analogs. And these have been mentioned already. And prophylaxis, if we talk about prophylaxis, also passive immunization by human hepatitis B immunoglobulin. Then you can talk about active immunization by the vaccine itself. So either the immunoglobulin or the hepatitis B vaccine. The vaccine itself, we know that it was introduced at first as a purified surface antigen derived from plasma of a healthy. But after about 5 years, since 1982, after 1982, they actually genetically engineered it. And that has been what has been used since. You know, that it is recommended for newborns, for children and adolescents not vaccinated at birth. Anyone who has sexually transmitted infection, including HIV, person can take it. Healthcare workers, emergency workers, and other people who come into contact with blood. And men who have sex with men, people who have multiple sexual partners. They are all recommended that this vaccine should be taken. People with chronic liver disease, people who inject illicit drugs, sexual partners of someone who has hepatitis B, and also travelers planning to go to an area of the world with high hepatitis B infection rates. That is where we have noted to be very endemic. And so I will end by sharing some of the work that we have done the last few years. This was the first work somewhere in 2012, where fatal hepatitis E viral infection in pregnant women in Ghana. That was a case series. This work was done with colleagues from Korle-bu in the NICU area. There were patients there who were having spontaneous abortion. And I mean, initially, the clinicians were struggling to see what was the problem. That is, especially those in their second or third trimester, I mean, pregnant women. So a sample was taken from one of them and were able to detect hepatitis E. And this is one of the first work that we did, and that more or less gave us some interest in working on hepatitis. So hepatitis E, realized that I think research is still being done. Hepatitis E in pregnant women at that stage is very fatal. Sometimes they lose the unborn child, that is through, it comes out spontaneously. Sometimes to even the mother also dies. So this work was very interesting and more or less gave us some interest to do more work on hepatitis. Then some two other work that we did. The first one on my left is a hospital-based surveillance for viral hemorrhagic fevers and hepatitis in Ghana. This, we were actually working on viral hepatitis, on viral hemorrhagic fevers. In the north, I mean, cases were seen which clinically looked like viral hemorrhagic fevers. And most of them, clearly we thought they were yellow fever because you can see the yellow coloration of the eye, the skin, it tinges and all that. We saw things that look clearly like yellow fever. So samples were taken, worked on, but in the end, most of those cases turned out to be fulminant hepatitis. So this is also a very interesting study that we did somewhere in 2013. Then on my right, we have etiology of viral hepatitis among jaundice patients presenting to tertiary hospitals in Ghana. So here too, we realize that most of the jaundice patients that were around, it was not only like similar to the previous study. We were seeing hepatitis E, co-infections with hepatitis B. And it was interesting. These are patients who were negative for hepatitis B, surface antigen was not there, but E was there, and we were having in E with sometimes C, E with B. Now that these are patients with jaundice. Then recently we did some work on the circulation of hepatitis delta virus and occult hepatitis B virus infection among HIV and HBV co-infected patients. That one was in Korle-bu. And one of our students did that. So that one too, we looked at the prevalence of hepatitis D among patients who are already hepatitis, having HIV and co-infection with hepatitis B. How many of them were having hepatitis D, and how does it affect disease progression? So that is also another interesting work that was done. Then hepatitis C too have done some work on the infection among patients with sickle cell disease, also at the Korle-bu Teaching Hospital. That one too, were able to look at hepatitis C prevalence among patients who were having sickle cell disease. Then only a year or two ago, we started doing or joining the train for creating awareness and making sure that we advocate for hepatitis during the World Hepatitis Days. So 3 years ago, we started screening and vaccinating communities during the days that have been declared as well. That is 28th of July. So tomorrow will be another day for going around and making that awareness or creating awareness and educating people. So we started this on the university campus for the first time, that is 3 years ago, quite successful. We got data from that and we published. Then after that, we also did another one at Mamobi only last year. And that importantly, what we did was we added another arm to it. We included the school, the JHS students. So what we do is that we go to the cluster of schools in one of the suburbs in Accra, give them materials, and we quiz them. So at the end of the series of quizzes that we do in the individual schools or cluster of schools, we bring those who will win for the final contest at Noguchi, and we award them. But the idea is to create awareness about hepatitis in these young ones. And not only them, we advise them to take them home, let their parents know what hepatitis is, especially hepatitis B, and the havoc that is wreaking in our communities. So this year too, we are doing that. We have done that already. In fact, we finished the final quiz last week. and we are preparing to go and screen. We'll be screening tomorrow and also vaccinating people free of charge at, we are going to Medina Market, close to the STC yard at Medina Market, where it's not too far from the Malcolm within the market area. So all those who are around the vicinity should do well to avail themselves. If you know that you don't know your status when it comes to hepatitis, please come. We will screen you first. We usually do the profiling, and if you don't have any antibodies, we will give you a vaccine. That is, if you consent to that, we will do that. So in a nutshell, I want to say thank you very much for the opportunity given me.
Thank you so much, Prof, for your presentation. We are so much grateful for having you. I would want to ask if there is any question from our members. Then we'll move to the last presenter. Is there any question?
Hello.
Yes, Prof. Come. Hello.
Yes, please. I wanted to find out the screening model. Is the RDT best for screening? And my second question also is about the number of years the birth dose protects a child. Like up to how many years can we give the 3 adult dose? At what age does it start from? Yeah, and the third question is on, I read somewhere that hepatitis B can be transmitted through body fluids, with sweat also being part of the body fluids that was mentioned. I wanted to ask about sweat being a mode of transmission. Is it scientifically proven, or yeah? Thank you.
Okay. Currently we have the last. I want us to quickly finish with the last presenter. Then we can take all the questions after. But there are a number of questions coming, so I would pray that you understand for me, so that the questions will come after the last presenter. You will be very brief. So.
Okay, so please take note that some of the questions are in the chat box, so that you can quickly answer them for us. Thank you.
Okay, very well. So our next presenter, we've read about his profile. Is in the person of Abraham Normal Nortey. His profile has been read already.
All right, thank you. Good evening to us all. Please, can you allow me to share my screen?
So while permission is being granted, is for Mr. Abraham Nortey to share his screen. I'd like to read his profile again. So Mr. Abraham Nortey is a highly accomplished individual who is currently pursuing his Master of Business Administration in Accounting at the School of Business, University of Education, Winneba, and Graduate Medical Program, that's popularly known as GEMP, at the School of Medical Sciences at the University of Cape Coast. His educational background includes a certificate in mental health, a Bachelor of Science degree in medical biochemistry and molecular biology, and
MSc in Public Health. Abraham's leadership skills and dedication to service are evident from his impressive track record of holding various leadership positions during his academic career. He was the former president of the Ghana Association of Medical Biochemistry Students from 2016 to 2018. He is the former president of the National Health Students Association of Ghana, NASAC, that's for the Volta region, Western region zones from 2018 to 2019. And he is the former president of the National Ghana Biochemistry Students Association from 2017 to 2018. Yes, he also served as the former chairperson of, his profile is very, very long. And he is also the former president of the Mental Health and Wellbeing Foundation, Ghana, Australia, from 2018 to 2020. Recently, he served as the former president of the National Association of Public Health Students from 2020 to 2022. Abraham is the founder of Visionary Normand Foundation and currently the managing director of the SB Star Medical Center, where he continues to demonstrate his passion for serving others and making a positive impact on his community. With his diverse background and impressive leadership experience, Abraham is sure to continue making valuable contributions in the field of healthcare and beyond. Ladies and gentlemen, this is our fourth speaker. Without much ado, I'd like to invite you, Mr. Abraham Noguchi, to start presenting, if you could give him the permission. Yes, and then educate us. Thank you.
All right, thank you so much, and good evening to us all. Please, the host should kindly help me share my screen. There is another name here, which is user. That is my laptop. I would like to share my screen with that. Please, a lot has been said. User, I think, yeah. Still having challenge sharing the screen.
Okay, I think you've been the host now. User has been made a host, a co-host, so you can share.
Okay. All right, thank you. All right, so I think a lot has been said already on hepatitis, Prof, and individuals that spoke earlier on. Thank you so much for putting me on, and I'm very happy to be here this evening to speak on hepatitis. I've noticed that what has been said is very in-depth, so I'll briefly move. My outline is to look at a global burden of hepatitis B, and also within the sub-Saharan Ghana, and some stigmatization and discrimination. Then look at some impacts on diagnosis, treatment, and prevention. Then how we can be able to combat the stigmatization and also promote inclusiveness. So according to WHO, this is as at 2015, the infection with chronic form of hepatitis B stands at as 257 million individuals globally. And if this as at 2015, it is very alarming to us to note that by as we find ourselves in 2023, there could be, the numbers have increased, and about 800,000 deaths per year worldwide, which is attributed to hepatitis B, liver diseases such as hepatocellular carcinoma. And you notice that with majority of patients that have chronic hepatitis B infections are found in Asia and Africa. And it was stated rightly by Prof that we have different types, the A to E, notwithstanding the B is one of them, which is of major concern. And the incidence of hepatitis B in these areas, especially in Africa and Asia, is frequently associated with deprivation, cleanness, and also other indicators. And a study by some researchers indicated that individuals that are infected with hepatitis B do not exhibit any signs, meaning they are asymptomatic, even though they are infected. And also, just a small number of portion of infected people acquire the chronic hepatitis B. And when you look at research, the number of Americans with the chronic hepatitis B infection is around 1.4 million, and is the main cause of liver cancer in their country. When we look at sub-Saharan Africa, where most of these chronic hepatitis B infections are found, it is imperative that public health pay more focus to this issue, because it poses a public health risk for women and children when it comes to hepatitis B virus. It is estimated as at 2016 that 7.5 million persons suffering from chronic hepatitis B infection as at 2015. And Africa has a sizable hepatitis B burden. Africa is also one of the leading continents in terms of the prevalence of chronic hepatitis B infection in the world, which is at 5.2% according to estimates somewhere in 2019. So it is very indicative that the troubling cause for hepatitis B have a greater chance later in developing into significant health issues, including cirrhosis and other liver diseases. And in sub-Saharan Africa, of which Ghana forms part, hepatitis B is one of the second most malignant in men, and also fit in most cancers in women. And it is thought that hepatitis B is responsible for about 80% of these cancers. The burden in Ghana has been, previous speakers have spoken much on it, but in Ghana, hepatitis B poses serious threat to public health due to the disease high prevalence. But it's rather unfortunate that, yes, so every year we come back to talk about hepatitis B, but we have a lot of unrecorded cases of hepatitis B. And most of there's a gap in the recording of the cases of hepatitis B, which in sense, sometimes you notice that even when WHO want to undertake projects or programs in relation to hepatitis B, they want to even be the lead rather than passing through the ministry, because sometimes the data that even comes out does not really, you don't see the trends very well. And the prevalence of this hepatitis B in Ghana made it so worse that the large number of infected people are unaware, which is they are asymptomatic of their condition, and they don't even tend to receive treatment and care because they are not even in the known of their situation. But about 21% of people with chronic hepatitis B infections are aware in a research conducted by Papo et al. As at 2019. So with regards to the prevalence, a lot has been said already. My focus is on the stigma and the discrimination. You would notice that hepatitis B not only affects the physical health of individuals, but also takes a toll on their mental and emotional well-being due to the social stigma and discrimination associated with the disease. Stigma arises from fear, lack of understanding, misconception about hepatitis B, leading to prejudice and negative attitude towards those that are affected. And this stigma can have a significant consequences and hinder effort to address this disease effectively. Hence, it is crucial to address this issue head on to create a supportive and inclusive environment for individuals living with hepatitis B. With the stigma, it can have a far-reaching consequences on individuals' health-seeking behavior and also hinder effort to control the spread of hepatitis B. There are some barriers to testing and diagnosis in the sense that with stigmatization, it often deters individuals from seeking testing and diagnosis for hepatitis B. The fear of discrimination or being judged as unclean or let's say contagious prevents even individuals that are infected with hepatitis from accessing healthcare services. And as a result, many cases go undiagnosed, leading to missed opportunities for early intervention and treatment. For obstacles to accessing healthcare services, individuals facing this stigma may avoid medical consultations or discontinue treatment due to the fear of being treated differently by healthcare providers or facing prejudice from others. With a lack of public awareness and education, I was so much happy when I saw this initiative because it's a step in the right direction in educating the masses. And as public health students, it is good that as yearly, it should be a mandate that there should be a public health education on hepatitis B. Just that the fear of stigma often leads to individuals keeping their hepatitis B status hidden and contributing to the lack of public awareness about the prevalence of the disease. And this lack of awareness can hinder prevention efforts, as individuals may not take precautions to protect themselves and others from the virus. In combating stigma and promoting inclusiveness, there's a need to address the public health awareness. And I was so much happy, as stated earlier, the launch of a comprehensive public health campaigns can be able to dispel this myth or misconception about hepatitis B. And education, as we all know, plays a pivotal role in reducing stigmatization, thereby fostering empathy towards those that are affected. There's a need for us also to promote empathy and understanding, where we can have an open dialogue conversation like we are doing today about hepatitis B to create a culture of understanding and compassion. Also, there should be advocacy and social support groups. Here, the support groups where we have establishment of hepatitis B support groups. And I'm so much elated when I heard about some of the foundations that are doing so well regarding public awareness on hepatitis B, where individuals can share their experiences, find solidarity, and seek emotional support. These groups or foundations can empower affected individuals to cope with the stigma positively. We need to also train most of our healthcare professionals. There should be policies which has already been spoken on, the media engagement, among others. So in conclusion, addressing stigma and discrimination associated with hepatitis B is fundamental to creating an environment where individuals feel supported and empowered to seek diagnosis and treatment and care. By working together to combat stigma, we can foster inclusiveness and also improve the lives of those affected by hepatitis B, ultimately leading to the better public health outcomes. And as public health students, your active involvement and advocacy in this area can make a significant difference in our fight against hepatitis B stigma. Thank you so much for your commitment to this cause. All right, thank you. Thank you. Yes, I'll be sharing my slides with you. Host, please, you can take it from here. So my submission was geared towards the stigmatization and discrimination, since a lot has been said. So I have to quickly change my slides in speaking with us all today. Please, any question?
Yeah, thank you very much, Mr. Abraham Norman Nortey. Please, are there any questions? And not only for him, but we want questions in general so that we can allow the presenters answer them now.
Okay, so I think some questions were placed in the chat box. I would like to read some of them out. But before that, please, an evaluation form has been placed, yes, on the chat. So please, let's fill it and then provide our feedback on the webinar. Okay, so Emmanuel Salifu asked, he said that in the recommendation for vaccine administration, it is stated that people with chronic liver conditions can be vaccinated. Can any of the speakers please throw more light on this point as to how true it is? And he continues to say, is this statement in relation to the chronicity in hepatitis infection or other causes of infection? So any of the speakers can try answering the question.
Hi. So, apologies, I dropped off. I guess I should get understood your question. One speaker said we should vaccinate hepatitis, people with chronic liver disease against hepatitis. Yes. So if you have chronic liver disease from hepatitis B, then you can get a hepatitis A vaccination, or you must get a hepatitis A vaccination if we establish that you don't have immunity against hepatitis A. And if you have a hepatitis, chronic liver disease or cirrhosis from hepatitis C, then you should be vaccinated against hepatitis B and A. A simple reason is that if you have a chronic liver disease or cirrhosis, any other disease of the liver, can actually make your cirrhosis progress faster or decompensate or progress to liver cancer. And so we want to prevent that risk. And that's why we vaccinate you against any virus that can potentially attack the liver.
Okay, thank you very much, Doc. Yes, Ms. Sarah Pobi also wants to know if a pregnant woman with hepatitis B prevent transmission to the child. Okay, he says, can a pregnant woman with hepatitis B prevent transmission to the child when the vaccine is given 48 hours after birth?
Yes. So, in fact, the vaccine alone can give you up to 90% protection, and the vaccine plus the immunoglobulin can give you a protection up to 98, 99% protection to the child. In fact, data has shown that up to 7 days after delivery, you still can get some protection, albeit the level of protection drops. The best recommendation, however, is that these babies must be vaccinated. I mean, I'm assuming we have a positive mother, must be vaccinated soon after birth before the baby begins to breastfeed. And the best results are often obtained within 72 hours. So you will still get some vaccination 48 hours after. Less likely so if the baby has started breastfeeding, but yes, you still can get some. But the recommendation is the earlier the better, if I put it that way. But also let me be quick to add that if you cannot get a vaccine, guidelines don't recommend that you hold on to breastfeeding, because that is also another critical requirement for the baby.
Yeah. So, newborn babies are and how many if
network in Surius, Tobon Papa.
okay, Dr. Tachi, please, Bonney, please, can you speak to the okay, please, just, some issues
In Ghana, a newborn baby would go into the EPI program where the vaccination starts at week 6. Now, that vaccine that is given to the baby comes with 4 other vaccines, and so it's a pentavalent vaccine. That is a totally different vaccine, and so an adult cannot go for that vaccine if they want to be protected only against hepatitis B, because the child then gets plus other vaccines. However, if you have a newborn to a positive mother, that baby also must get a hepatitis. So this pentavalent vaccine that I've described cannot be given to the newborn baby at birth, which is what we call the birth dose. So that vaccine must be given, that is given to the newborn at birth. It's similar to the vaccine that adults can take. There are only differences in the dosing. So the adult dose is different from the baby dose as would be for every child. And so once that baby gets that at birth vaccine, at 6 weeks, the baby now joins the EPI program and gets 3 additional doses, which would make it 4 doses. An adult who has not previously been vaccinated is free to join the vaccination program at any time and get 3 doses at 0, 1 month, and 6 months later. I hope I managed to answer your question.
Okay, thank you very much. Yes, someone asked a question to whether after taking the vaccine that protects you from hepatitis B for 10 years, is it okay to take another 3 shots or just a booster? And I think you answered rightly by saying that it is not mandatory even after 10 years, as we know that the majority of the general population maintain their immunity. You went on to say among high-risk individuals, example, the health workers, people on dialysis, and the recommendation is to check your titer. And if it has fallen below 10, then a single booster dose is required. Yes. So someone also asked the question. I think this one, Dr. Atsu, if you can kindly help us out. He says, what will be a treatment for a diabetic who has taken all the 3 doses of the vaccine, but took a scan and the report was chronic hepatitis? What will be the treatment regimen in this case?
Can you hear me?
Yes, please, I can.
Yes, I'm not really sure whether I understood that question very well. I don't understand whether it is referring to vaccine or medication or whatever. Yeah.
Yeah,
go ahead. Go ahead.
The scan diagnosis of hepatitis, chronic hepatitis, is not equal to chronic viral viral hepatitis B or C. Remember that I said many things can cause hepatitis. So if I have a diabetic whose scan says chronic hepatitis, I know with almost 90% certainty that this person is, the scan is actually referring to fat infiltration of the liver, which gives it a certain appearance, which can be misconstrued to be hepatitis. And oftentimes it's a non-alcoholic, if you like, hepatitis. So there's fat causing fat, if you like, non-alcoholic fat hepatitis, or also known as steatohepatitis. So it's not, it doesn't mean the person has a chronic hepatitis B or C. The treatment of that is totally different.
Okay, thank you very much, Doc. Okay, so someone also asked a question. The person says that, can we start the immunization of the Hep B vaccine for all newborns?
I mean, that is the WHO recommendation. And I know that Ghana is working towards that. I don't have the answer. I'm sure that other speakers may know why, but really, it's something we should all be working towards.
Yeah, Doc, to add to that, actually, it's recommended that it's universally given to all newborns. Though I know there are countries that give selective to only to children of mothers who were positive. The studies that support it show that it is a more cost-effective way of doing it. One of the advantages it brings, it protects the child from birth to 6 weeks from any horizontal transmission that might be within the environment. So universal birth dose is recommended for all countries. Thank you.
Okay, thank you. So someone asked the question. It says, has the WHO triple elimination initiative for elimination of mother-to-child transmission of HIV, syphilis, and Hep B been adopted in Ghana? If so, please when? Essence when?
Yeah, okay. Okay, I think I can address. I have tried to put a response there. What happens is WHO has made recommendations about triple elimination. These have been captured, and from 2024, actually this would be on ground. So it will become part of our national guidelines and will be implemented. However, once this goes with PEP dose, the big chunk of Hep B prevention is actually addressed. Thank you.
Okay, thank you very much, Rob. So the last question, and then we talk a little about the initiative. So someone is asking if, he says, for a child who gets the penta vaccine, how many years that protect more hair?
Protection from pentavalent vaccine is lifelong. In fact, it used to be thought that it was shorter, but then studies have shown that protection lasts almost lifelong. That even when it appears as if the child has lost immunity, the memory is there. Once the system is challenged, the child is able to, the one who, a child who probably at that stage becomes adult is able to respond appropriately. So once you get the birth dose plus the 3 other doses you need as a child, you don't actually need any hepatitis, hepatitis vaccination again, unless of course anti-HBS is done and some physicians are made, but this might be on case basis. Thank you.
Okay, thank you. And someone asked whether, he says, what should I do if I started but did not complete the full hepatitis B vaccine series? And then is there also a vaccine that will protect me from both hepatitis B and
Is there a vaccine that will do what? The voice was distant.
Okay, so the person says, what should I do if I started but did not complete the full hepatitis B vaccine series? And then went on to see there's a vaccine that can protect him from both hepatitis A and B.
Protecting him from both hepatitis B and
yes.
B and what?
A and B.
A and B.
Yes.
Oh, okay. Now, if you don't complete the full series, as soon as you know that it's not completed, it's good to go and do it, because there should be a minimum interval between the doses. Of course, it works even better when it is maintained as such. But once you remember, or it is remembered for the child that it has not been done, it's important to do it as much as possible. The only constraint in this is that if the child now has to be more than 1 year before taking the third dose, for instance, then it does not contribute to the coverage for children under 1. Now, there is a vaccine for both hepatitis A and B. So those vaccines too, they are available. I think A vaccine is even in Ghana for travelers.
Okay. Thank you very much. Yes. So I would like to say a big thank you to all our speakers for today. We've been in this thing for almost hours now, and they have really shared insightful knowledge about hepatitis B, vaccinations, management, treatment, causes, epidemiology. We are so grateful for this, for giving us, yes, some of their time, and to dialogue with them about hepatitis B. Yes, as students, we need to know more about these and then spread the good news of hepatitis B. Let people know what hepatitis B is about, and also try to reduce the stigma and then the discrimination that exists for people living with hepatitis B. So we are very, very grateful to you, Dr. Atsu. We are grateful to you, Dr. Kenneth Tachi. We are grateful to you, Prof. Bonney. We are grateful to Mr. Abraham Nortey. You have really given us so much insight into hepatitis B. Yes, so please, if you want to leave, you can please leave. At the point that we are going to speak a little about. Yes, please, the slides and then the recordings will be shared. Okay, thank you too. So at this moment, we'd like to talk a little about the Africa PHS, and people have asked a lot of questions about Africa PHS and what we do. So I will share my screen and then we will talk a little, about what we do as an organization, but this will be facilitated by another person from our headquarters. Yes, so I will share the screen shortly and then she will present on it.
Okay, please, you can. Hello, Mariam, please, if you're around.
Hi, Antonio. Can I? Hi, Antonio.
Yes, you can please continue.
Am I audible?
Yes, you are audible.
Okay. Okay, great. 1 minute. My name is Miriam Zakaria. I am the project manager for the Africa Public Health Students Network Initiative, a very amazing organization and one I would encourage you to be a member of if you aren't a member. I'm from Nigeria and I will just briefly talk about what Africa PHSN is all about. Next slide, please. I also want to apologize because I have been having so much network issues today. So if along the way you can hear me, you can just leave a message in the chat. I will try to figure it out. I'm also sorry I can't turn on my camera because it's late here. Okay, so what is a public health initiative, which is popularly known as Africa PHSN? It's a community of students in medical and health-related fields. So basically, it's an organization that tries to bring students, both undergraduates, in other health-related courses such as veterinary medicine, pharmacy, nursing, dentistry, maybe lab science to the medical field, public health as well, and any health-related field. For me now, for instance, I studied veterinary medicine. So yeah. Next slide, please. Okay, so what mission? Our mission at Africa PHSN is to create a platform where future health professionals come together. So we have like this common goal. We want to kind of like learn, want to conduct quality research, and the overall goal of the organization or the overall mission of the organization is in Africa. Or we are not just one particular field can improve the public health sector in our region, that's Africa alone. We need like a collaborative effort. So the organization tries to bring together people in these various health-related fields that I mentioned earlier, to learn. That is through all these webinar series like the one we are having, through workshops and the like. This webinar also qualifies because we're also advocating, or we are trying to create awareness about hepatitis and other health-related issues that are affecting Africa. And we also try to conduct quality research with the improving the public health sector in Africa. Okay, so now you kind of like have an idea and really Africa PHSN, it's kind of like run on, we have executives, and then we have the national working group, like the Ghana National Working Group, we have Nigeria National Working Group, and we also have like a team in each of these national working group that also work to try to ensure activities are conducted at in coordination and in sync with what the organization wants to achieve. So benefits of being a member now. So why should you even be interested in being a member of Africa PHSN, it's good idea, or it's very good for you to be a member of Africa PHSN. Firstly, you have a chance to volunteer and support health workers in providing interventions. You also access to public health education. You have this opportunity of attending conferences, attending webinars, attending workshops that are focused on public health, on different public health aspects. You can, as a member, you can also be involved in advocacy programs. You can be involved in research, and of course, we have like this World Health Assembly simulation that we are currently working on. By being a member and being an active member, if I may say so, you also have a chance to make an impact in Africa's health sector, which is like very important because, when you look at, there are so many different public health issues around the world. And most of the time, when you look at the prevalence, when you look at the epidemiology, you realize Africa is always like among the first 10 in most of these diseases. If you want to talk about malaria, for instance, Africa is there. If you want to talk about zoonotic disease, for instance, rabies, you always see Africa having this high burden, or this burden, if I may say so, when it comes to different public health diseases, different public health issues. So being a member and being an active one, you have like this chance to make an impact in the Africa's health sector. Next slide, please. Okay, you also have an opportunity to network and connect with other students around Africa. So Africa PHSN is not just a country-based organization. It's like Africa, so you get to interact with people from maybe Ghana, people from Ethiopia, people from Nigeria, for instance. Like it was through this organization I got to meet, I think, Rexford, who is from Ghana, and that way I can also learn a lot from him. I can learn about the situation of different health issues in Ghana, for instance. Or for instance, if let's say I want to conduct a research, and you can just have like this opportunity to network, create friendship, which in turn would probably benefit you moving forward. As a member, you have access to intern with our partners and public health institutions, and you also get discounts for meetings, courses, and products. Next slide, please. Okay, so I've talked about what we do. After you gain, I've also talked about the mission of the organization. I would like to talk about the programs that we do at Africa PHSN. So we have our focus includes education and research. It involves advocacy, surveillance, and volunteer programs. So for us here in Nigeria, we have like this volunteer program, and when we have, let's say we have an outreach program, a physical event, as a volunteer, you can then participate in the outreach program and join in creating awareness. This has some of the key focuses. Like when we have events, we try to organize the events around these activities. So far, we've been able to do so many activities, both on the African scale, like Africa as a whole, and on the different NWG level. When it comes to malaria, we had like this World Malaria Outreach Program and video competition in Nigeria. I know they also had, I think, a radio program in Ghana as well during the World Malaria Day, and also during the Antimicrobial Resistance Week last year, we had numerous activities that were held during this period, which involved both physical programs aimed at creating awareness, as well as online sessions like webinars, among the likes. So if you're somebody that is like passionate about public health, you're from Africa, you really want to contribute, and you see that, okay, there's a need, there's like this need to improve the public health sector in Africa as a whole, then one of your key steps could be joining Africa PHSN and trying to see what you can gain as well as what you can contribute. I know there's a fee that Okay. There's like a fee that you pay to be a member. It's a very small fee that I believe should be convenient for you to pay. And you can check africapHSN.org for more information about how to go about being a member. And of course, you can reach out to the different teams in the Ghana NWG that are currently on this meeting. I'm sure they can also provide their email address in case you want to email them, or maybe a contact address that you can reach out to. I hope briefly I've been able to talk about Africa PHSN. And please, can we go to the last slide? Yes. Key things you can check: africapHSN.org, www.africapHSN.org. That's our website. And you can email publichealthstudentsnetwork@gmail.com if you have any queries, any questions. And yeah, you can also reach out to your UGs as to also inquire about this. Thank you so much. And I will just stay if you have.
Okay, thank you very much, Mariam, for this brief presentation. Yes, we have been here for quite a while now. Yes, I would like to express my deep-seated gratitude to all of you for joining this program. The program started with over 150 people. We have about 39 participants. Yes, at the moment. We are grateful to you all for staying till this time. We will communicate to you the processes involved in registering for this program via the various platforms that we have on our WhatsApp platform. When you go to this website, you will see details of us. We'll also send you emails and then text messages, yes, to brief you more on the processes involved in registering for this organization. So thank you all for joining. Our partners, we are grateful. We are grateful to all our partners, that's Radio Universe, and to the National Association of Public Health Students, the University of Ghana Health Students, the University Nursing Students Association, the Pharmaceutical Students Association of Ghana, the Federation of Ghana Medical Students Association, of Ghana Medical Laboratory Students Association, and all our partners. We are grateful to you for making this program a success. Yes, unfortunately, we will not be able to introduce everyone. Yes, but we are grateful to you all for joining this program. To our speakers, we are grateful. There's nothing less than gratefulness or gratitude that we can express to you. We are so indebted to you for sharing your insights with us on hepatitis. Yes, we will send you emails and other messages to update you on the processes involved in registering to become part of this organization. So let's stay tuned. Until then, it's a goodbye, and thank you all for joining this program. Yes, please, you can turn on your videos. We would like to take a snip of our videos before we go off. So please turn on your videos, and then I'll take a snip of it. Okay, please, some people have not turned on their videos. If possible, please turn on your video so that I can take a snap of it.
Okay, so thank you all. Yes, and hope to see you another time. It's bye-bye for now.